All right, everybody, good morning. I'm glad to be here. And as Dr. Waller said, I've been hospital-based of one sort or another for actually my 31st year, and I've rotated around different things. I kind of like doing everything. And I got old, and I said critical care, I like it, but I'm a little too old for it. So now I'm a full-time hospitalist. About a third or a little more of my patients are pulmonary, so I'm still doing a lot of that as well. And the two lectures I'm going to give you today are pulmonary lectures. One we're going to see here on community acquired pneumonia. The second one is going to be on asthma. I don't have any disclosures. Learning objectives are going to be for this talk to identify how to determine if patients with community acquired pneumonia should be treated as outpatients, inpatients, or in the ICU. So we're going to talk about patterns and things of being able to look that way. Describe antibiotic recommendations for patients with CAP based upon their clinical settings and a degree of severity. So how do you treat them? What antibiotics do you use? That's going to be a key part of the lecture. And recognize the utility of some of the laboratory testing. So the first stuff, which is really review for everybody, is what are the history and physical exams. And again, not every patient reads the book. They don't have the clean stuff that you like. But typically, fevers, chills, sweats, productive sputum, yellow-green, shortness of breath, plus or minus pleuritic chest pain. So really, fevers, chills, sweats, productive sputum. Those are really the key hallmarks. Again, not every patient gets them. The physical exam, they're febrile about 80% of the time, at least at the time of presentation. Less in elderly, so your elderly patients may not spike much of a fever. They may not get as much of a white count. Respiratory rate is typically elevated in at least half to two-thirds. Tachycardia is common. And there's evidence on exams when you auscultate or look for E to A changes and so forth, about one-third of the patients. Typically, you have an elevated white count. If you have a low white count, on the other hand, that's a negative prognostic factor. So hypothermia, low white count with pneumonia, that means the body is getting beaten and not fighting it adequately, so something to keep in mind. Now, chest x-ray is interesting. So you have to have radiologic confirmation of pneumonia. It's part of the definition of pneumonia. So it's the fevers, chills, sweats, productive sputum clinically, but also an abnormal radiologic study, typically a chest x-ray. Now, however, if the clinical, this happens all the time, is that the radiologist will then call infiltrate on chest x-ray. And you're going to say, wow, that's pneumonia. The truth is, it's not always pneumonia. There are a lot of pneumonia mimics. And one of my mentors once taught me that the following 4 things cause infiltrates on chest x-ray. He called it blood, cells, water, pus, and I added pulmonary fibrosis. So when you're looking at a chest x-ray, there's 5 things that cause abnormalities in the alveoli. Again, blood, which is alveolar hemorrhage, pus, which is pneumonia, which can be an acute pneumonia, chronic pneumonia, immunocompromised host pneumonia, cells, which could be cardiogenic or non-cardiogenic edema, water cells, cells which could be malignancy, and then fibrosis, different types of interstitial lung disease. So keep in mind, not everything that looks like an infiltrate on a chest x-ray is pneumonia. And if you get someone admitted from your emergency department with an infiltrate and you're told it's pneumonia, but they don't have fevers, chills, sweats, productive sputum, or something else, they may still have a sort of a more subclinical pneumonia, but keep in mind it can be a whole bunch of these other things. I'm having trouble going backwards. All right. Could you go back about 3 slides? Okay, that's great. Thank you. Okay. Good. So I wanted to point that out. Now, when the clinical is not consistent with pneumonia, consider these other things. On the other hand, if you have a high clinical suspicion, this guy's a fever of 39, has a white count of 17, is having fevers, chills, sweats, waking up at night sweating, productive sputum, you really think it's pneumonia, then the question is it a false negative chest x-ray? Again, either one can be off. You could have findings on chest x-rays that are not pneumonia. You could have findings or clinical of pneumonia that's not seen on chest x-ray. Well, what could it be? Well, it could be an early infection. So infection is the bacteria, but the infiltrates on the x-ray is usually the inflammatory response to the bacteria. The number of white cells is much greater than the number of organisms.